In 1811, Benjamin Rush unveiled his masterpiece. He called it the tranquilizer. It was a chair, heavy oak, bolted to the floor. The patients sat with their arms strapped to the rests, their legs bound, their chest immobilized by leather restraints. But the innovation was at the top. A wooden box enclosed the patient's head entirely, padded, lightless, designed to restrict all sensory input while holding the skull perfectly still. Rush explained the reasoning in clinical terms. Mental illness was caused by irregular blood flow to the brain. Excitement, agitation, mania, symptoms of vascular congestion, too much blood, pumping too forcefully, pressing against the delicate tissues of the mind. The tranquilizer reduced stimulation, calmed the pulse, allowed excess pressure to subside. Patients sat in the chair for hours, sometimes days. Rush recorded the results with satisfaction. Patients emerged quieter, less agitated, more manageable. He did not record how many emerged broken. Benjamin Rush was not a monster. He was the most respected physician in the early American Republic, a signer of the Declaration of Independence, Surgeon General of the Continental Army, professor at the University of Pennsylvania. He was called the father of American psychiatry, and he believed completely that madness was a problem of pressure. Too much blood, too much force, too much congestion inside the skull. If pressure caused madness, then relief meant release. This belief wasn't new. It wasn't uniquely American. It was the culmination of 2,000 years of medical reasoning. And it wasn't entirely wrong. Before biology, the body was understood as a vessel. Physicians couldn't see neurons, couldn't measure neurotransmitters, had no concept of electrochemical signaling. What they could see was fluid, blood that pooled, sweat during fever, bile rising during illness, phlegm accumulating in the sick. Health meant balance. Disease meant excess or depletion. The brain was no exception. Galen taught that the brain produced animal spirits, subtle fluids flowing through nerves to animate the body. When these spirits moved correctly, thought was coherent. When blocked, compressed, or overheated, madness followed. Symptoms seemed to confirm it. Mania brought flushed skin, racing pulse, hot scalp. What else could this be but too much blood pressing against the brain? The logic predates Galen. Hippocrates described trepanation in the 4th century BC. If symptoms worsened after head trauma, intervene, cut the scalp, scrape the bone, open the skull to release what was building inside. The instructions were precise, technical, taught. Archaeologists have found trepanned skulls from Peru, France, Kenya, China, 7,000 years old. Many show healing, bone regrowth, months, years of survival. Some show clear signs of trauma. And here's the uncomfortable truth. For those patients, trepanation may have worked. A blow to the head can cause bleeding beneath the skull. Blood accumulates. Pressure builds. The brain has nowhere to expand. This is an epidural hematoma. Without intervention, it kills. The modern treatment: open the skull, drain the blood, relieve the pressure. Ancient surgeons didn't know the mechanism, but they knew the pattern. Head injury, worsening symptoms, intervention, sometimes survival. When survival followed intervention, belief hardened. The theory wasn't tested. It was confirmed by outcomes. If pressure explained trauma, Why not everything else? Seizures looked like internal explosions. Hallucinations like compression of perception. Mania like overflow. By Benjamin Rush's time, the model was total. All disease came from irregular arterial action. Too much force, too much tension. The cure was depletion, bleeding, purging, blistering, cold baths. Rush bled patients aggressively, pints at a time. Critics accused him of killing more than he saved. He rejected this completely. Those who died, died of the disease. Those who lived proved the treatment worked. The logic was sealed. Medicine doesn't need to work perfectly to survive. It only needs to work sometimes. When intervention preceded recovery, the treatment was credited. When intervention preceded death, the disease was blamed. No controls, no comparisons, just repetition. And occasionally, it did work. Bleeding reduced blood volume. Cold shock interrupted agitation. Sensory deprivation exhausted the mind. Doctors saw improvement. They attributed it to pressure. Bloodletting was taught into the late 1800s, recommended in textbooks until 1923, 2,000 years, abandoned not by refutation, but by replacement. The logic didn't disappear. It evolved. In the 1932nd, Egas Moniz introduced the prefrontal lobotomy. Pathological circuits were the problem. Sever them, and symptoms would stop. Pressure reimagined. Release redefined. Moniz won the Nobel Prize. Tens of thousands were lobotomized. Some patients calmed. Some were destroyed. The logic endured because sometimes it worked. That was enough. Pressure wasn't superstition. It was interpretation, built on observation, reinforced by outcome. Ancient doctors weren't ignorant. They were attentive. They did what doctors do. The difference is, we now have tools to test our explanations. They didn't, which raises the question this channel keeps asking. What explanations do we accept today because they work just often enough? What treatments persist because success is credited and failure is explained away? The pressure model lasted 2,000 years. It felt like science. It felt like progress, until it didn't.